Is visible the screen?
Yes, sir. Yes, sir.
Okay. So, another question. So the definition of obesity is an abnormally high amount of adipose tissue compared to lean muscle mass. That is the simple definition. It's quantified by using the BMI, which is also called the Quicklets Index, 18 kg divided by height in meter squared. And also can be calculated using what is called Broca's Index, which is height in centimeters minus 100 for men and 105 for women. And it is also ideal body weight, which is 20% considered as 20% more than the ideal body weight is considered as obesity. And you can also use what is called the tricep skin fold testing. 23 millimeter, more than 23 in male and more than 30 in female, where you can use this calipers to measure the forceps, skin fold thickness. And waist circumference more than 102 in men and more than 88 in women indicate obesity. And waist to hip ratio more than 1 for male and more than 0.85 for female is also one of the method of quantification of obesity. So this is how you measure the waist to hip ratio, one at the umbilical level and another at the anterior superior level, and then measure the make the ratio. The risk for increases with the BMI increases is a strong predictor of ischemic heart disease, stroke, diabetes mellitus, and death. So that is why obesity is considered as a disease, not as a aberration from normal health. So the patterns are peripheral or gynecoid, central or android, and this classification, there is another classification based on the BMI, where normal is 18.5 to 25, overweight is 25 to 30, class 1 is 30 to 35, class 2 35 to 40, obese class 3 is 40, more than that is super obese. The role of BMR in pathophysiology is more intake and less expenditure results in weight gain. And resting energy expenditure is very low compared to the exercise. So exercise increases the energy expenditure not only during exercise but post exercise up to 18 hours it increases. So to achieve weight loss, regular exercise will be helpful to increase the BMR, and also calorie restriction will also, combining with this caloric restriction, it will help in weight reduction. And the excess calories are consumed or stored in adipocytes in the form of triglycerides. And what happens to this adipocyte when the fat gets stored in them? They increase maximum size up to BMI of 40. Beyond that, what they do is they increase in number also. So they go on increasing in their size up to BMI 40. After that, they start multiplying. So in clinically severe obesity, that is what is happening. The central obesity, there is an enzyme called lipoprotein lipase, whose activity is more in the abdominal fat than in the hip fat, and this causes the higher incidence of metabolic disturbances, and that is the reason why central obesity is considered more dangerous than peripheral obesity. Insulin resistance develops because fatty infiltration of pancreas leads to decreased secretion of insulin, and increase in size of adipocytes causes resistance to insulin because the adipocytes secrete pro-inflammatory substances like interleukin 1, 6, and macrosis alpha. And there is another important hormone secreted called leptin, which is secreted by adipocytes, which is a hormone for satiety. It modulates energy expenditure and food intake, acting on the hypothalamus. And this gets disturbed. So all these things, three things lead to insulin resistance. And the role of momental adipocyte in obesity is it is infiltrated by because of that causes the increased influx of fatty acids, hormones, and cytokines, which stimulate liver to produce low density lipoproteins and lipoprotein B. This stimulates pancreas to produce more insulin and polypeptides to cause diffuse intracellular inflammation in the initial phases. Later on, what happens is it decreases the insulin production when this fat gets infiltrated into pancreas also. So the genetic factors, mutations in the gene controlling hypothalamic melanocortin receptor, which is involved in appetite suppression. So this childhood obesity is more common because of this genetic factor. So this melanocortin receptor, which is present in the hypothalamus, causes increase in the appetite. So these children start eating more and more and gain more weight because of increased calorie intake. Similarly, homozygous mutations in genes responsible for the balancing of the two hormones called leptin and ghrelin, which are counterproductive. One leptin is a satiety hormone, ghrelin is a hunger hormone. So when the more ghrelin secretes, you feel hungry more. When the leptin is less, you feel you require more leptin to cause a satiety or fullness. So when the leptin is reduced, you don't feel full. And ghrelin causes more hunger. So this ultimately causes increase in the intake. Environmental factors, increase in consumption of high calorie foods and decrease in physical activity. Psychological and socio-economic factors. So if you are quite rich, you always go for high fatty foods and all junk food and start eating them. And the eating disorders. There are some psychological eating disorders called binge eating syndrome and night eating syndrome, which all also lead to increasing food intake. The endocrine pathologies that can happen are metabolic syndrome, diabetes, Cushing's, and hypothyroidism. So always ask the history of hypothyroidism, which may be the sole cause for obesity sometimes. Gastrointestinal pathologies, non-alcoholic steatohepatitis, hiatus hernia, fatty liver, gallstones, and GERD. Musculoskeletal disorders are OA, backache, and inguinal hernia. Malignancy, common malignancies are pancreas, kidney, breast, prostate, uterus, and colorectal. And other ailments are kidney failure, psychological depression, shortened life expectancy are the other ailments in obesity. Coming to the system-wise problem, respiratory system, there is a restrictive type of lung disease because of added weight in the chest and thoracic cage. Decrease in FRC due to impedance at the descending of diaphragm. PRV and PLC are also decreased. Closing volume may exceed FRC, which will result in VQ mismatch. And why pre-oxygenation? There is a 50% reduction in FRC compared to the 20% in non-obese patients. So it is very important to pre-oxygenate obese patients before GA to prevent desaturation. OSA is defined as cessation of breathing for more than 10 seconds during sleeping time. And what are the symptoms? Sleep apnea, daytime somnolence, impaired concentration, memory, headache on waking up. And it can be ascertained by asking the stop back questionnaire. Stop you have snoring, tiredness, obstruction, and pressure. That is hypertension. Bang, BMI, age, neck, and gender. The gold standard test for that is polysomnography. And sleep apnea can be classified as central and peripheral. Central sleep apnea, there is no respiratory effort and is due to central respiratory center depression. And polysomnography is done by admission overnight in the hospital. The whole process is videographed. And EEG, ECG, pulse oximetry, electrooculogram, chin electrogram, airway microphone, elastic belts over chest and abdomen to measure the respiratory efforts. 2-leg EMG to monitor leg movements are all attached. Recording done for total of 6 hours while patient is sleeping. No narcotics or no sleeping drugs to be given to the patient. It should be a natural pattern of sleep. And it helps to diagnose central, peripheral, and mixed types of sleep apnea. And it can be, the severity can be assessed as mild, moderate, and severe. It also measures the arousal index, how many times the patient wakes up per hour, and the respiratory distress index can be obtained by combining the apnea-hypopnea index with arousal index. The serious effects are systemic hypertension because of increase in the insulin effects on the sympathetic nervous system, and leads to angiotensinogen release as well as sodium retention. There are the reasons for hypertension. Cytokines release damage arterial vessels leading to fibrosis and stiffness. That is another reason for hypertension. And the uncontrolled hypertension leads to concentric and eccentric LVH, causing heart failure and pulmonary hypertension. And weight loss can completely resolve this hypertension. As I told you about diabetes also. And how much of increase in cardiac output is required during weight gain? It is 100 ml per minute for each kg weight gain. So if the patient puts on more and more weight, the heart has to pump for every increase in 1 kg, 100 ml per minute. The causes of CAD in these patients are chronic inflammatory state, dyslipidemia, hypertension, and diabetes. And DM also causes progressive atherosclerosis, which is another reason for the coronary artery disease. And what is metabolic syndrome and what are the other names for that is, it is also known as syndrome X, insulin resistance syndrome, and Rehaven syndrome. These are the three names for that. It's characterized by increase in waist circumference, which is central obesity, hypertension, insulin resistance, and decrease in good cholesterol, HDL cholesterol, or increase in triglycerides. And any three out of these five will be considered as fitting for metabolic syndrome. Now, why you are worried about metabolic syndrome? It's sometimes it may cause the sudden death. All of you would have heard about the recent calamity that happened in one of the hospitals in Chennai, where a bariatric surgery patient died on the table. Probably he was suffering from this metabolic syndrome, we do not know. How to treat obesity? Patient motivation is very important. Diet restriction and exercise, and medical therapy that is used as serotonin or norepinephrine uptake inhibitors, widely used, like pentyramine and fenfluramine and sibutramine, because of and they cause appetite suppression. So the intake is reduced. That is the mechanism how it is working. And there is another common drug prescribed called orlistat, which is a lipase inhibitor, which prevents fat absorption from the gut. It is still in use in some patients. And there is a drug called ephedra, which causes increase in energy expenditure and it's an over-the-counter medication, with lot of serious side effects. So it is not advisable to take that. The surgical option for that is surgical bariatric surgery in the form of restrictive, malabsorptive, or combined bariatric procedures. Points in the history you have to do is focus on CVS for chest pain, shortness of breath at rest or minimal exertion, palpitation, respiratory symptoms like OSA, snoring, use of CPAP, BiPAP, exercise listening, or previous surgery, DVT, GERD problem, medications, and control of comorbidities. What should be focused in physical examination? Check for CVS RS involvement. Airway examination, I have highlighted in red. It's very, very important to predict difficult airway, both for mask ventilation and intubation. And peripheral venous access, that you should assess during the preoperative examination itself. Select the particular good vein, and as far as possible, cannulate it by an experienced person instead of the novice trying and spoiling the available 1 or 2 veins. Only an experienced person should cannulate those veins. IVC filter may be used if the patient has earlier history of DVT. Investigations, routine blood test, LFT, RFT coagulation profile, ECG for ruling out LVH, RVH, or extreme heart disease, chest X-ray, echo, polysomnography, if OSA is diagnosed, ABG, breathing pneumonia. And what are the pre-op instructions? Continue home medications except OHA, ACE, ARB, and the anticoagulant drug. NPO status, anti-aspiration prophylaxis, to bring the CPAP and BiPAP equipment. This is one of the important instructions if the patient is using this. And thinking of giving heparin or low molecular weight if there is a history of previous DVT. Plan for intraoperative management. You must decide between GA and RA. So based on the airway, patient position, and duration of surgery, all these things will make you decide whether you can go for GA or RA. Advantages of RA are SAB, epidural, nerve blocks and plexus nerve have the following advantages. You are not going to meddle with the airway, so there is no risk of difficult airway or failed airway in the aspiration risk. And you can use less opioids, so less respiratory depression. Disadvantages, technically challenging since landmarks are obscure, limited duration of anesthesia, unless you put in a catheter and prolong the duration of anesthesia, and inability for the patient to lie flat for longer periods of time. And most important precaution is to, even if you choose RA and in case the single shot subarachnoid wears off, you must be in a position to convert it to GA. So unless you are confident that you can convert to GA, it's better to go for GA straight away rather than choosing RA and in between struggling and trying to convert. And what points to be checked intraoperative management, general anesthesia, all the team members should be familiar with the problems of managing obese patients and should be able to perform their role properly. Pre-medication only with the drying agents if anticipated difficult airway is there. Avoid sedatives and opioids if there is a history of OSA. Class 3 obesity patients may need larger operating tables. Transfer of patients from trolley to OT table may be a challenge unless special rollers are available. Side support should be checked and fitted properly. These are all some of the examples of morbid and supermorbid obese patients. And if you anticipate difficult airway, ramp or help position is ideal. Difficult airway cart should be checked and kept ready. They have a good assistance to give birth maneuver or a 2% mask holding. Always check the cricothyroidectomy kit and be ready, and also mark the position of the location of the cricothyroid membrane so that in the emergency you will not be struggling to locate it. So always mark it with a marker pen and keep it ready. And the presence of ENT surgeon will be very much helpful in the whole situation. Or you can plan for an awake fiber optic intubation if you have a confirmed difficult airway. So how is the correct ramp position assessed is, this is the bad position. You can see here there is no alignment here. It should be equivalent to the external auditory meatus. The suprasternal notch and the external auditory meatus should come in the same line. Whereas here you can see it is not going across to the suprasternal notch. So that is very important to get the correct position. Challenges in monitoring NIBP, we have discussed extra large cuff is needed, or you can put it in the forearm. ECG lead placement may be ideally done correctly to get the maximum size complexes. Temperature monitoring because they become obese, hypothermic. Urine output monitoring to measure the perfusion and fluid status. All pressure points to be padded properly. Preventing patient sliding is very important. So we have this is the PTK cuff applied to the forearm. This is how we do that. And this is are the slides, the supports to prevent the sliding of the patient. And steps during DA are secure IV access properly, either in the periphery or in the central. All monitors to be in place. Pre-oxygenation is very vital. An assistant may help in securing the airway. Patient should be in the head-up or ramp position. Calculate the dose of the various drugs used. How IV propofol based on total body weight, whereas if you give the infusion, it is on lean body weight. And Saxa is also used on total body weight. On the neuromuscular blocking agent, atractidine is also loading dose given on total body weight. Fentanyl on lean body weight. All lipophilic drugs tend to have long duration of action given by total body weight, so you have to use your discretion to adjust the dose. Airway management, PP tube or third generation LMA. Here you can aspirate the gastric contents if they come out. The preferred mode of ventilation is pressure control mode with a suitable ratio of minimum peak airway pressure, and PEEP to ensure adequate oxygenation. Oxygen, air, CO, and desflurane are the choices of inhalation agents. Monitoring neuromuscular paralysis to titrate the neuromuscular blocking effect will be useful so that we don't over paralyze. TIVA and TCA using remifentanil and dexmedetomidine is advocated for bariatric surgical procedure. Ketamine and dexmed infusions is also recommended as a sole intraoperative anesthetic for bariatric procedures. Fluid requirements are given on lean body weight and not on total body weight. And the precautions followed during emergency are patient should be in the semi-upright position. Use pressure support ventilation with PEEP before reversing the neuromuscular blockade. Extubation carried out in the upright position when the patient is fully conscious, alert. And transport to HTU ICU in the same position, not in the full recumbent position, with oxygen supplementation and monitoring of pulse oximeter, oxygen saturation, and verbal contact to assess the wakefulness. These are all the things you have to do. Post-op pain is managed by multimodal analgesia using regional NSAID, alpha-2 agonist, and ketamine and magnesium sulfate. Lignocaine, also infusion by infusion route. Ventilation in obese patients with severe require mechanical ventilation. So less severe cases can be managed with CPAP and supplemental oxygen. Prevent DVT prophylaxis, early ambulation is mandatory, and manage nutrition. Enteral nutrition feeding will help in preventing protein calorie malnutrition in these patients. Wound infection and poor wound healing also can happen if nutrition is not taken care of in this patient. So this is a small mnemonic I thought of for quick remembering the points of managing this obesity. You can remember a prime minister at a public function. So A stands for airway, P stands for position, M for monitors, A for again agents, T for technique, P for pain relief, and F for fluids. So totally 7 points you have to remember. So if you gather all these things, then you will be able to manage this patient well. Okay.
Sir,
Ah,
sir, is it safe to use LMAs with a BMI of more than 40, sir?
yeah. They have done third generation LMA with facilities to aspirate whatever regurgitates or comes to the pharynx is safe for the thing. They have done it especially for cholecystectomy itself, where intra-abdominal pressure is raised by pneumoperitoneum and then surgery is being done. Even in those cases, they have found that using third generation LMA with the gastric conduit is very, very safe. And you can pass a right tube also through that if you want it. You know, sometimes the surgeons want a rail tube to deflate the stomach. So you have the option to pass the rail tube also in third generation LMA. Okay?